Welcome everyone to today's program. I am Kathy Brett with Becker's Healthcare. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenter will attempt to answer as many questions as he can during the time we have and will follow up on questions he does not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenter. Mr. Kelly Webb is the Vice President and General Manager of the ASC Billing Division of Medigain, LLC in Plano, Texas. As a business development consultant, Mr. Webb leads a specialized team of associates that drive ambulatory surgery centers into 40% higher profits. By reviewing the overall business model and understanding medical insurance companies' requirements, they drive revenue higher. Mr. Webb is the founder and former CEO of ASC Billing Specialists. In this role, he helped to instruct, teach, and guide doctors to great business decisions, teaching them business principles and allowing them to govern themselves in order to maximize profits. Mr. Webb instructs and consults with doctors on how to maximize profits and has helped improve revenues by as much as 40%. Kelly has spent 10 years interacting with insurance companies daily and is lead negotiator with medical insurance companies to receive 80% payment on surgery bill charges for out-of-network claims. He has consulted with doctors on provider contracts and all aspects of medical business as a liaison between the insurance company and the provider. Kelly received his BS at Brigham Young University. It is now my pleasure to turn the floor over to Kelly to begin today's presentation.
Thank you, Kathy, for that introduction. I really appreciate it. It's a pleasure to be here today. And I also appreciate all those that have taken time out of their busy schedules at surgery centers to tune in and listen up to a few things we have to say today. Just a quick brief history. A lot of you may know us from ASC Billing Specialists. We've been in the industry now working with ambulatory surgery care centers for about 7 to 8 years. And recently we just joined teams with Medigain, which gives us deeper resources to actually provide better increased revenues across the board. And we're real excited about that. Today we're going to talk a lot about out-of-network, but I also know that a lot of you already have hybrid systems where you have a couple of contracts out-of-network and network, and we'll discuss that a little bit. I've also had a lot of recent inquiries as to how the new Obamacare laws are going to affect the ASC market, but we are going to definitely not talk about that right now, and we're just going to try to cover some of these information, but we do have information about that, and you can inquire about that later. So at any rate, I'd like to kind of get into the presentation just a little bit. We're going to cover, we have the next slide, please. So you can definitely reach me at this particular email as well as this phone number, and it will show up again later in the presentation. There's our current website and a phone number that you can call for information on how to market your ASC, how to increase your revenues, how to interface with the insurance companies, et cetera, et cetera. One of the reasons that we work in this industry is because we believe that doctors provide a very valuable service to people, and we have a true motive of the fact that they really need to be paid properly in order to continue their jobs. So we like to focus a lot on different types of out-of-network concepts, and we'll see a lot of that and talk about it because a lot of people don't clearly understand how to utilize it in today's market. And we'll definitely move through this, and any questions you have on any of the other areas that we can help with, we'd be glad to answer. Just feel free to contact us. So next slide, please. So today we'll be covering the truth about out-of-network. Next, there we go. A little focus on that as to what it means to be out-of-network these days and just exactly what insurance companies are doing. Why your ASC should either go out of net or create what we call a hybrid, where you have a few contracts that are out of network and some that are in. We'll discuss the PPO benefits, a little bit changes going on in that market, and it's actually for the better in most cases, and how you can literally explain out of network to your patients so they understand it and avoid any of those ongoing hassles you might have. And we'll look through the payer mix. That a payer mix is key to going out of network. You have to understand your current geographic area and the benefits in your area in order to do that. And we'll also discuss how contracts are manipulated by the insurance company. Okay, I just got a note that we weren't able to hear me too well, so I'm going to try the speaker box. Let's try that. There we go. Try this. So if we're talking about out of network on the next slide, please. Dealing with that, the PPO market, well, the insurance PPO, is still being sold in record numbers. There's recent research and numbers coming in from other organizations that there's 69% of Americans with health insurance still have coverage through a PPO. That's over 204 million people. 204 million people are insured through PPOs. In fact, most Americans want that choice especially. If you sit back and think about it for just a moment, the old HMO model that was popular through the late 80s, early 90s has kind of phased out. It's starting to phase out a lot, where a lot of people don't want to deal with a referring source provider. They want to go directly to the specialist that they want. They're researching more online. They're understanding more about their health care, and they would literally want to go to the specialist or pick their specialist, and they're researching it. So the HMO product is dropping down in the insurance market, and the selection of choice in the PPO is increasing year after year after year. This is driving, there are huge premiums that are paid by any of the given employer groups. Those employer groups matched with a match coming in from any existing employee, which are your patients, has been increasing time and time again. In fact, the medical insurance companies, if you go back in history and just research for the last 4 or 5 years, you can see records where they've increased at 20, 30, 40% increases. They asked for a 40% increase, Blue Shield did, in California about 3 years ago, and that was turned down. 2 weeks ago in the Wall Street Journal, United Healthcare released a press warning. It was an article, but it was talking about the fact that due to the strength of Obamacare and things that were going to change their industry, they were warning that they were going to have to increase their insurance premiums. If you keep an eye on that, they're constantly charging more and more for what Americans want in the care base.
I'm sorry, there appears to be a little technical difficulty. Kelly, are you still on? One moment, please. We'll be back.
Yes, I am. Can you hear me now?
Oh, yes, we can hear you now.
Okay, I apologize for that technical difficulty. I was in the middle of speaking, but I don't know what happened. Something changed for the hold music, so I apologize for that interruption. And if I could just continue, we were looking at the fact that the insurance companies were being paid huge premiums by the employer, but what we're also seeing, everyone's seeing that, is that if you're out of network, you're seeing things that are restricted by daily max caps. Well, here at Metagain, within the division of ASC billing specialists, we have all kinds of different solutions to help you with those strategies and issues that you can overcome any of that information and still continue to use these great out-of-network PPO benefits. It is a benefit that the insurance company provides, and so those ambulatory surgery centers that utilize that benefit know that things are a lot better in the usual and customary market than they are at Medicare fee schedule. Next slide, please. I'd like to continue. Thank you. One of the things that will drive and project as to how you look at your whole surgery center and its profitability and management is to actually do an analysis on your payer mix. We find as we talk and consult with a lot of doctors and a lot of ambulatory surgery centers, and yours may be the exception, but there are those that manage their surgery center from their bank account. And what I mean by that is they literally have a certain amount of charges that they run their business, they pay themselves at the end of the month, the doctors pay themselves, and it definitely causes that at the end of the month they check to see how much money's left, and that's what they're looking at for management, how their business is flowing, where the checks came in and where they went. We propose that you'd look at your payer mix analysis, which is literally going to tell you where your money is coming from, look at the insurance companies, the insurance payers, and what companies your businesses get paid, and then 100% of your Medicare patients. As you do that analysis, you're going to want to find out and understand that if you're 100% Medicare-based or that you have contracts that are 100% Medicare-based for your geographic area, then you might want to look at changing and adjusting that. You can't grow in your industry if you can't tap a resource of more money. And I just spoke about an hour ago to another ASC recently, and they definitely had a hybrid mix. And it makes sense for their geographic area, and that's what we're going to analyze here. Next slide, please. I want to show an example of this for the payer mix. Thank you. If you look at this payer mix, and I apologize if it should be okay on your screen, you should be able to see this, but you come down and you put in, you list your payers, you'll put in all the charges for any given month or a year, you can base it however you want, put in your total number of cases, your payments, and then you're going to run the two columns of the average of the payer mix and the average payment, and then a percentage of revenue. This gives you a whole bunch of different data that you can then analyze your practice. If you look at the bottom, this is basically this particular payer mix is for clients that have an awful lot. This particular one was done on a client that had an awful lot of in-network contracts with their surgery center, but they have a few that are out of network, and it kind of highlights in this slide that we can look at it. So once you have all this data laid out, notice that we're showing a payer mix of 76.93 Medicare or lower than Medicare contracted rates. So this particular ambulatory surgery center is a lot of those that are contracted across the board trying to make business, and you're getting 76% of Medicare or lower. If the sequesters have gone through, sequesters drop in Medicare, and the Medicare system is, as we know it, financially broke. Congress is constantly scrambling to find money to keep paying Medicare. It's something they're going to continue to do. They're going to continue to support it. But as you know, just last year, I think it was last July, we had a time period there where no Medicare claims processed. For almost a month, we were all waiting for the government to fund Medicare once again. Now, if you sign new contracts with a lot of insurance companies, a lot of those are tied to the Medicare fee schedule. I would highly recommend not to sign a contract tied to the Medicare fee schedule. As the reimbursements go down in Medicare, so goes any contract tied to, say, Blue Cross or Aetna or United Healthcare that's tied to a percentage of fee schedule is going to go down as Medicare goes down. They tie it directly to that. They set that up in advance knowing as a strategy that the Medicare reimbursements are going down instead of up. So your ambulatory surgery center is also going down. So if you come back to the payer mix and you look at it for a second, and you're getting paid less than Medicare or fee schedule, Medicare has always been what we call a push in accounting. For the most part, your costs in Medicare are generally straight across the board. There might be 3 to 5% profit margin in there to keep you running a little bit, but a lot of the Medicare fee schedule is built at cost. It's not meant to actually create a profit line. It's just generally a push or a straight across charge, and therefore you're not going to make a lot of money at Medicare rates or sub-Medicare rates. You're definitely losing money in some cases, depending, of course, if you have implants or other things. So on this particular one, there's only 128 insurance claims processed, but as you go down through it, it gives us a lot of key information. Next slide, please. So as you look at this, it's going to tell you, and you set up your own payer mix, you're going to show you what you do, how you get paid, which is your best insurance plans. It's going to highlight that for you, and I'm going to talk over that in just a minute. And how do we do more business with the best insurance plan? and how can we steer our ambulatory surgery centers as a business to more cash faster. Well, here at Metagain, we have all kinds of concepts for marketing, increasing your revenue, more timely payments. We actually enhance your doctor's ability to actually streamline and direct your exact revenues to different insurance companies, because it's become more and more particular as to how to work with an insurance company. We can help do that in a lot of different ways, that we can analyze your practice, analyze your surgery center, and actually drive more benefit, more revenue to the bottom line. Next slide, please. Let's go back to this spreadsheet and look it over for a second. So if we're looking at this screen and we go through it for one moment here, if you pull up to, I'm off just a little bit, but the marker on the top right side, it's marking, should be on Aetna. And if you notice the charges, they had 9 cases, they had payments of 28, but its payer mix was 6.92% of the total revenue. So it's a fairly high paying group of insurance, and his average payment was $3,149, or 22% of the revenue. So if you're looking at 22% of the revenue in 9 cases, and then you drop down 3/4 down the page, you see Medicare where that marker is, and come across it, they had 39 cases of Medicare. Charges total was $21,000, and you look at the payments, they only received $19,000 total conglomerate for a 30% of their payer mix. So this particular surgery center is 30% based on Medicare with an average payment of $510. And then the next thing I want to point out is that you take a look at Gallagher-Bassett. That marker's underneath it, halfway up, right across the line there. They did 2 cases of Gallagher-Bassett. They got payments of $13,437. This is an out-of-network payment for 1.54%, or the average payment was $67.18. Well, if you look at the percentage of revenue at 10.53%, you have to step back for a second and ask yourself, where do we want to grow? Do we want to increase Medicare? And do we want to work 4 or 5 more Medicare cases for a 1 or 2% increase in our bottom line? Or would we rather get 4 more cases of, say, Gallagher-Bassett cases for 30% of our revenue, where we're getting paid better? So you literally are analyzing and saying, how do I work my system to actually work smarter and get paid better revenues for the same work we're already doing? We can help with that. We can help direct you at that. We actually have strategized marketing that we can help you target your best employers, and as we target your best employers, market directly to the employer group so that you can bring in the best benefits that are in your immediate area by analyzing that. Next slide, please. Actually, go back to that for 1 second, if you would, Kathy. I apologize. I want to come back for 1 second. I wanted to bring in one other point, and that is if you look at this, the payer mix is literally a percentage of how much of the doctor's time in that, or the surgery center's booked rooms percentage is being used on that case, and the percentage of the revenue is how much money is being derived from that length of service. So he's spending 30% of his time for only 15% of his revenue, and if you look at Gallagher-Bassett and he spends 1.5% of his time, he spent an hour and a half out of 100 to bring in 10% of his revenue. So if it makes more sense to him actually spending more time, 10 to 12 hours on 5 to 6 or 8 more cases, he would literally triple that number to 30 and 40% of revenue. And you want to go through every one of these insurance plans and think of ways that you can increase and drive more patients or your better payers to your surgery center, and this is how you'll grow your business. So when I use numbers and say things, next slide please, when I use numbers and say things like our company will help you increase your revenues 10 to 30%, we are adamant about that literally happens. It's not something that's just a salesman's pitch. We functionally will do that and actually help your ASCs increase, provided that you follow the direction and the type of marketing that we help put together and everything else. So this is kind of a conclusion from the payer mix. We've pretty well covered this verbally, but literally again, are you spending 30% of your time on Medicare for just 50% of your revenue? And I'm not knocking the Medicare. Medicare is a great stabilized platform that you do cases, keep your doctors working, book your rooms, but you can control that environment too. There's ways to not overdo your center. If you had 100% utilization of Medicare, you have no room for growth in your operation and your actual scheduled surgeries. So you need to utilize other strategies to increase revenues in that area. And if you have too much Medicare in your surgery center, then schedule those out a little bit farther. Use your scheduling to defer that just a little bit and move it more across. Next slide, please. Thank you. So if you should decide from the payer mix and you look at it that if you want to increase your revenues and you want to increase it, say, with a United Healthcare or with an Aetna or a Blue Cross or even a Cigna, then you're going to need to be able to explain to your patients and to your customers a little bit more about out-of-network. And the way you want to start that is you want to start with the benefits of an ambulatory surgery center versus a hospital. Now, hospitals are fantastic. They save lives every day. But there's a difference between an ASC and a hospital. A hospital derives revenues from about 8 different sources. If you go down and think through the hospital's line of products, they charge for the room, they charge for the prescriptions, they have their own internal dispensaries, they are charging for the beds, they're charging for the surgeons. They have a whole line of products that they're charging the insurance companies for and or the public that they create revenue from, where an ASC only gets it from one surgery, from the ambulatory surgery center for the room, and that's really the only one line item of profit line that they really carry. So now, but the benefit here is that the doctor literally in an ASC is required to be on site from start to finish. So if there's any trouble with the patient, the doctor's right there. You have a registered nurse on site required by law. If you research a lot of the public newspapers, a lot of hospitals have fired an awful lot of staffing of registered nurses because they didn't want to pay those payrolls. And instead they're substituting with people who were not quite as well trained as an RN, let's say. It's documented that there's a lower infection rate with a hospital. I mentioned that once to a lady working in the ASC, and she had ties to the hospital and she took offense. I am not offending the quality of any clinician who sterilizes an environment. That's not the point here. The point here is that the public does not visit grandma at an ambulatory surgery center. In a hospital, when you go into a standard hospital, everyone's coming in to visit the sick. So it's bringing in all of the diseases and everything else from the outside, and you have more and more impact. Where in an ambulatory surgery center, that person's in a sterile environment. They're there. They don't have an overnight stay. They're done on a few surgery procedures, and they go home. It's easier to keep that environment sterile. Okay, point taken. Good enough. Better surgeons are out of network because they can be. So a lot of our surgeons across the country have gotten so fed up and tired with having to deal with the hassles of getting paid by the insurance company, they've gone out of network. And if you take a look at cancer with Mayo Clinic, for example, they charge cash all the way across the board for a lot of things, as well as a lot of others, and literally will functionally continue to work because people will come to that level of service. So the example here is that the better doctors are out of network because they know they can still get paid, and people want to go to the best. I personally had that experience this past week of having a family member taken to a surgery center to actually have a rotator cuff surgery. And when we went to have that procedure formed, the doctor's office of the orthopedics was trying to get us to go to the hospital, and we said no. Just for the reason of the lower infection rate, we definitely want to go to an ASC, which we did. And I was very pleased and very happy with the care. And the public will pay for that. The public wants to do that. And so literally you want to structure this so that when you talk to your patients that you're able to help them pay, understand that the benefit of going to an out-of-network facility or even to an ASC is worth it compared to a hospital. Next slide, please. Okay, so one of the things that we highly recommend is that you have an actual insurance coordinator that explains the benefits and costs to the patient. Print out their benefits from offline, go over it with them, take the 10 minutes. So if the doctors have a visit or they've recommended someone to their ASC, as you're doing the pre-verification and you're pulling their benefit, email it over to them and then have someone call them on the phone. If they're in front of you, sit down and go through it. Call them on the phone and go through their actual benefit for both in-network and out-of-network and explain it to them. Once it's explained and you enhance the understanding of it, patients will clearly get that the best place to actually have their surgery done is in an ambulatory surgery center. And it's quite easy to be able to explain those benefits to them in a manner that puts them at ease before and after the surgery. And you can even have your patients come in a little bit earlier for the pre-op to have that benefit explained to them if you choose to do that. I recommend do it days before as you're scheduling it, but still set their expectations. You want to set their expectations so that it's not a surprise later, obviously, and have the cost pretty well spelled out to the best of your ability. And we have all kinds of guides and helps that we can do with that to help explain that to patients. And so literally one of the best things to look at is to talk about, and I'm going to go to that in a minute, of the insurance verification. But before I go there, there's another concept that I definitely want to be on the table, and that is if you choose to go out of network with any given provider, it truly means that you need to understand the employer's plan benefits. Next slide, please. So if you or your ASC wants to take, say you're in network, but you're not getting paid what you should be with Cigna, for example, and you decide that you want to go out of network, you clearly want to understand the employer's benefit. Years ago, the insurance companies had very few plans. If you were with United Healthcare, a lot of the doctors will still say, well, if United Healthcare claim, how come it's not paying as well as the last United Healthcare claim I just processed? The answer is in the fact that the benefits have all changed. In the last 2 years, we've seen a cafe menu of assortment of benefits and benefit plans. And as an administrator, or an ambulatory surgery manager, even as a doctor, you need to understand the employer's plan benefits. Benefits are decided by the employer groups as they set those up with the insurance company and not by the insurance carrier. So if you have General Motors in your given geographic area, you have a plant there, and you have Northrop Grumman, and then you have a UPS warehouse facility, and you see all those three employers coming to your surgery center, and they all have United Healthcare, let's say for an example. Just because those three carriers come, they've all picked separate benefits. And I think a lot of you in the industry are already aware of this, but it's amazing how many people don't clearly understand it. The menu of the benefits change, and they could have over 300 different benefit plans just in your given area. And so those need to be clearly understood because each business has a select menu of benefit. Some will elect the max cap, 350 daily max, or we've seen it in all those. Well, if you're out of network with that carrier and there's a max cap, you still are able to consult and talk with the patient and charge the patient because you're out of network. So therefore, you can discuss that with them, go over their benefit, come up with a payment fee structure that meets your fee structure, help them understand it, and work them through this case, and they still come out as a beneficiary, even with plans at 60-40, 70-30, and it varying by your employer group. These things are constantly changing. So as our ambulatory surgery centers lean on us, we constantly are feeding them more and more information. We have teams of people that are in touch with the insurance companies, and we will actually touch about 400 different times in any given day to any given separate insurance companies. So we're constantly on the phone, we're constantly interacting with them as they change some of their plans and modify procedures to how they process claims or anything that they do. We're in touch with that. Because we have so many touches with them, they literally keep us informed as to what's coming down the line or what's new, and we can help your surgery center adjust to that. And that's what this note is that plans change in October and roll out January 1st. I had a doctor call me and said, well, I want to know what happened here. I was getting great benefits with this company, and all of a sudden this has changed, and it's February 2nd. Well, he hadn't even paid attention that particular company we'd noticed him and told him that company had changed their benefit plan in October, and it was going to roll out in November, and that they started doing the work in February. Well, that plan had changed. The payment on that plan had changed, and therefore it affected his bottom line as to what he was getting paid. But those changes are always ongoing, and that's why you use an outsourced company such as Metagain to actually keep in touch with that and keep you informed both in-network and out-of-network, of changes in the insurance industry. Next slide, please. Thank you. Insurance pre-verification. Insurance pre-verification is rather an interesting area. The medical insurance company is a unique area. There's another industry that you can call in, ask to be approved to do something. They give you the contract. They give you the go-ahead. You go ahead and do the contract, and as you're listening to the tape recording, it says, oh, just because we verify this doesn't mean we're going to pay for it. In any other industry, if you hired a pool contractor, or if you hired an auto repairman, or if you hired a lawyer, or if you hired an accountant, and you said that kind of a disclaimer to any of those industries, they wouldn't do the work to begin with. But because our medical industry is so unique that these doctors literally swear by the Hippocratic Oath to do no harm, to take care of people, they go ahead and do it, putting them at risk to actually get paid. Well, I don't care if you're in-network or out-of-network, you can see that the insurance companies do not always pay properly. And if you're in-network and you have a contract and it's loaded into their system, their claims processing system, why is it that there's 20 to 30% claims that are underpaid and denied? It's a computer system. The contract fee schedule for that CPT code is loaded. It's right there. So how is it gets out the back end as a change? Isn't that interesting? Well, the answers is that the insurance company has its own policies as to how they pay and when they pay. The chief financial officer there is totally looking at his bottom line every day, and he may stall or delay payments so that he can have a better reporting for third quarter. He wants to keep a little money back and not pay as much, and so he creates 40% stalls, which holds his money back. He gains interest on that once the quarter passes. If the billing clerk in your office sends an appeal or a change or calls and says, why was this denied, and they don't just write it off, then they'll reprocess it and pay it. But in the meantime, he's held back that money that literally should be going to the doctor. So if you call the insurance company and you ask them different questions, they won't teach you. But during the insurance pre-verification, there are real key questions to ask. And one of the key questions is, how will this claim get processed? I don't think enough people ask that question. You need to literally ask them, how will this claim get processed? And regardless if you're in network or not, you want to know how they're going to price it, how it's going to be structured. Is it going to stay on the fee schedule that you're already contracted to? Ask those questions up front. Take down the name of the person you spoke to, the time, and their ID number, and then the reference number for the call. And then you have documentation that you can back up when you're following on the claim. If you're out of network, you definitely want to ask questions as to how does this claim get processed. You also want to ask, how will they determine the allowable? The allowable is the amount that they allow on the billed charge. So if you bill $20,000 and they only want to allow $18,000, that's the allowable. But the way they determine it now, they become more specialized, where they will pick randomly or based on plan benefit, they will pick a daily cap based on if you're tied to a Medicare fee schedule, usual or customary payment, or another program such as MNRP, which is maximum non-reimbursable program that United Healthcare loves to tie to all the time. So it's important to ask all the right questions when you're doing an insurance pre-verification. Next slide, please. Now, the following slides are pretty condensed. There's a lot of information on them, and it's kind of hard to go over in this type of a seminar. But if you follow up with us and send an email, we'll definitely help you with this form and help you with this information, because we want people to be able to get the right types of verification. And if you look towards the bottom, it'll talk about the different benefit levels. And so you really want to look at how the different benefits, how they're going to process it, if they're in-network on these different procedures. So there's a whole list of information on this form, and if you go to the next slide, and I apologize that it's so small on the screen and maybe hard to read, but it talks about the insurance verification, and literally is the plan or subscriber itself or another person information available, and the effective date. How often do you have an effective date if someone comes in to see your surgery center And we see this occasionally that they lost their job 2 days before, so therefore there is no benefit unless they've picked up a spanning insurance. And it wasn't verified 2 days before. It was verified 2 weeks or 3 weeks when the surgery was scheduled. No one verified it at the last minute. Therefore, it turned into a cash-based patient. That could be frustrating to a lot of different surgeons, especially if there's a lot of hardware involved. But these particular insurance verification forms have a lot of really tight questions. Go ahead to the next slide, please. Real specific questions that you can ask the insurance company about their fee structure, how they're going to pay, what's going on with it, if they're tied to Medicare, or exactly what else is going on. And like I said, I'd be glad to get you this information if you want to send an email or call the 800 number, the 888 number, and we can email this over to you or make contact with you and discuss it, because we'd love to see people that get better information on doing an insurance pre-verification. As you can tell, it's really lengthy and detailed, and I'm not going to go through every step on this, but it literally boils down to being certain that you're asking all the right questions. And if you're having any structural issues about getting paid, you want to check this area of the insurance pre-verification, because no one really teaches how to verify something. You have people that have been doing it for years. It seems to be okay. Well, things change. They need to ask new questions. So you might want to make sure that you're updating them along the way. Next slide, please. And this is just the other half of that question, of the questionnaires. These last two sheets do the insurance verification for the form that was before that. So like I said, we'll get to see. Let's go to the next slide. Okay, why would you want to go out or hybrid mix? Well, basically, bottom line is that the insurance companies are trying to squeeze. If you look at the profit that, you go online and you start researching the profit, United Healthcare is grossing more dollars in a quarter than the combined gross domestic product of some of the Central American countries. So if you compared Guatemala and Honduras, and you look at some of those countries for their whole gross domestic product, the revenues in 3 months at United Healthcare are higher than that. When you look at that kind of a size of an epic company, they know how to manage their money, and they're doing it at the peril and the cost of a doctor. So at some point, you want to really be in touch with where you're from, how you're getting paid, and then look and see if in your geographic area through your payer mix, if it makes sense to go out of network. And if you want to go out of network, we can literally train any group of doctors with any specialties that's done in an ASC how to do that properly, so it's a smooth transition, educating your patients, training your staff, flowing through that, because your benefits that are being dictated to you by the insurance company, they're coming to you through the payer mix, and you're literally going to be shopping for the best employers with the best benefits, because back to the payer mix, you want to increase in that revenue. That's the way to do it. And almost all geographic areas now in the United States have better PPO benefits. If you go and look for that and find it, then you literally have a lot more choice of expanding your given business in the surgery area. So, and this will work literally for, if you're totally contracted, you can still take a look at it and see, does it make sense? And we can help you drive methods to actually push back and tell them that you need to have an increase in your contract in certain areas. There's a lot of, it depends on the leverage you have in your given area. Smaller rural areas where you're the only large provider and have influence over a population base, you have more influence and leverage with the insurance company. If you're an orthopedic doctor in downtown LA, you don't have as much leverage because there's another orthopedic doctor less than 10 miles away that United Healthcare can take their business to. But there's still sense that makes strategy to actually make your center more profitable. If you're only making 3 to 5% profit margin, you need to actually look at that and increase it. And the benefits are available because they've been paid for by the employer, by the patient. And for a surgery, that's the kind of thing that they really should be tapping into those and actually utilizing those benefits. Next slide, please. Okay. One last thing on why go out in the hybrid mix. there's all types of ways to structure having one or two contracted provider or insurance companies, Blue Cross and Cigna, for example, in network, keep them in network, take Aetna and United out of network. There's all kinds of strategies for mixing that mix and understanding it and helping your fee structure flow with that. You can legally do that. It's not an issue. And you can legally manage it too, and it's profitable. It makes your surgery center more profitable. And literally the manner and the method that makes sense in today's generation. Okay, how contracts are manipulated. I get the opportunity to review an awful lot of contracts with doctors. I am not a lawyer, but I am a businessman that understands what's in the contract. We had a surgeon, a plastic surgeon a while back who contacted us, and he'd hired someone to help with his contract, and it was a very poor contract. We advised him not to sign it. He went ahead against our wishes and signed it anyway. In that contract, it was called out and stated that he was only, whatever surgery he did, he was only going to get paid for the first CPT line. So whatever one procedure he did, he was only getting paid on that one line. Well, when he did a breast reduction, you charge it out on two lines, he was getting paid for one breast and not for the second one. That makes absolutely no sense. It's a horrible contract. We're getting it canceled, getting out of it. We're helping him do that. We asked him not to do it in the first place, but we're going to help him get out of it. Now, one of the reasons that comes up is because they slip all kinds of information in there, hidden enrollments, hidden networks. There are an awful lot of still third-party insurance companies. First Health was an example. Multiplan was like this for some length of time, where they have hidden networks that if you sign with them for your city and your area of 100,000, 150,000 lives, as you sign their contract, they have a reciprocity agreement built into the background that says once you contract with them, you're literally contracted across the board at their rate. That's the important thing. If they're only paying you at, say, 75 or 80% of Medicare, and you contract with them, that reciprocity agreement puts you in network with Blue Cross, Aetna, Cigna, and everyone else at that lower rate. So if you've picked up different plans that are out there, there's all kinds of these third-party plans coming through, and you're unaware of the backdoor deals or the reciprocity agreements. They're called hidden networks in the industry. You could be all of a sudden have a great contract with Blue Cross, but all of a sudden your reimbursements have dropped 10 to 15%. And if you're not tracking that and keeping track of it, you don't know why. Well, it's because the reciprocity is something you never saw. It should be illegal, but they do it all the time. Something that you never see, that reciprocity agreement in the background, was put in play by this other insurance company, the small-based insurance company that came to you. And I have a whole list of names of those on these reciprocity agreements of who they do. And it can take 3 to 6 months to get out of it. So all of a sudden it's affected you across the board with Blue Cross, Aetna, United Healthcare, and you didn't even know it. So there's all kinds of these hidden enrollments. There's hidden networks. As you track your payments, you'll see that 15 to 20, maybe 30% in some cases are underpaid, and you call up the insurance company and say, hey, wait a minute, we have a contract rate to be paid at this number. Oh, I'm sorry, that must have been processed incorrectly. Let me reprocess that for you. And what do you know? You get an additional payment in a week. Well, why wasn't it processed right the first time? And if someone hadn't called or contacted them on that, would that money have ever been generated where it should have been? That's one of the things that we do is we're highly incentivized to actually go after every dollar that you're due and make certain that these are paid at fee schedule. Make certain that they come in properly. They're paid per the contract. And if you have carve-outs, that your carve-outs are getting covered. We track literally every one of those so that any given claim that's processed, we find out about it. Now, as you're negotiating a contract, you obviously need a lawyer to go over the terms and create fair terms for you before anything is signed. You don't want to have anything signed without your lawyer reviewing it because, especially a healthcare lawyer, you need to literally have that benefit of your own attorney reviewing it so that it's clearly explained so you're not caught up in some of these things. And remember as you're doing that you want to be able to negotiate in a contract. A contract is a binding agreement between two parties. Well, try telling that to the doctor who just started his own practice, fresh out of residency, puts up his own practice and calls Blue Cross and says, send me your contract. They won't negotiate with him for anything fresh out of school. they want to give him something at 70 to 80% of Medicare and say, here, this is all we're going to give you. Well, that's not a two-party agreement. So feel free to push back on terms. They want 180 days cancellation clause. Push back. Tell them you only want it at 60. They want to give you only 15 days to get them a medical record, or they're going to deny your claim. You adjust that. You push back. You say, no, we won't do this for less than 60. If you ask for a medical record, we should be allowed at least 30 days or 60 days. It's in your contract. Whatever you have becomes law. So push back on those terms that are favorable to you. This whole concept of the contract manipulator is a whole other seminar. But the bottom line to keep in aspect is to utilize someone who has the scope that can see a variety of contracts across the board and be able to negotiate on terms that are fair for you. And then don't sign anything until it is that it's acceptable and really does what you need it to do. There's obviously compromises that come and go with this in this area, and I'm not claiming to be an expert on it. I do see a lot of contracts, and I do totally understand that I've heard all kinds of horror stories. And in fact, a lot of you should check all of your, as you look at United Healthcare's contracts, and if you charge more than 5 CPT lines, go and see what you're getting paid on the 4th and 5th line of the CPT charges. Check that within your area and find out what you're literally getting paid on the 4th and 5th line of all those contracts, because you might be surprised as to how things are treated on the claims processing. With that, I have just a few minutes left. Next slide, please. We'd like to open it up to questions and see if we can respond. Oh, excuse me, I want to start with this one more reason here. Sorry, I forgot this for 1 second. But there are 6 reasons why you should allow a Medicaid ASC billing specialist to manage your account receivables. And this view graph kind of really explains it. We can definitely do a payer mix, an EOB, and revenue analysis to see where you're at in your whole surgery center. We do that to help you enable that. We really love and are specialized in doing global billing to help you understand that. Perhaps you could change some of your billing if you're out of network. Also, we enhance your staff. We're not here to replace anyone. We'll work with them. We actually do a lot of teaching and training, and we'll even help you transition to a more positive payer mix. We have concepts and abilities to help you literally increase your revenue. We've shared a couple of those. There's a whole gamut of other methods and opportunities to help you increase your revenues. And when we say 47 to 73%, we have strategies for that, and if you choose to work with us on those, we can definitely deliver those numbers. We also have an ability for a lot of ASC marketing best practices. We can teach and train your team and anyone you want to how to get better clients. We're doing that successfully with a lot of our clients, and they're extremely happy. And the last thing here is we do ongoing upgrading and compliance to be ensure that your ASC is going to survive. We're in tune with the industry. We listen to everything that's stated about it, and we stay highly involved. And you'll see us at the ASCA conference coming up in Boston. You'll also see us at Becker's conferences and other conferences around. So keep looking for Medigain and ASC Billing Specialist, the division of Medigain. And I'd like to thank you very much. Next slide, please. I'd like to thank you very much for your time, and we'd like to open it up to some online questions. We also have a panel that's answering questions along the way here.
Okay, well, thank you, Kelly, for your excellent presentation and for all of you who are participating today. Just as a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. And we'll attempt to answer as many as we can in the remainder of the time we have. Kelly, I have a couple of questions right out of the box here. Is it legal to bill out-of-network claims?
Yes, that's an interesting question. Is it legal to bill out-of-network claims? I've been asked that several different times, and yes, obviously it's legal to bill for an out-of-network claim. If you are not in network with any given provider, it's okay for you to literally process that bill out-of-network. I've had people at seminars come up to me and tell me that someone told them it was illegal to bill for their surgery center for an out-of-network claim. I think there's a lot of misinformation that is spread around the industry for fear. just for fear to try to control people so they don't literally process and get paid what they should be getting paid. But yes, absolutely, it's legal to bill for out-of-network claims. Next question.
What is the most important question to ask when I verify benefits?
I think one of the most important questions to ask is something we kind of covered a little bit, and that is how do they determine the allowable? You want to know if there's going to be a daily max cap, if it's going to be tied to the Medicare fee schedule, or if it's going to be processed as usual and customary. The insurance companies actually pick and choose as to what they want to do. Sometimes it's locked in with the provider benefit. Other times they literally will pick and choose how they want to process it. So you need to know that up front before you actually handle the surgery, because it affects your reimbursement on the back end. You want to know if it's being tied to, say, an MNRP program or something else. But thank you. Next question.
Do in and out of network cross accumulate?
An in and out of network claims do cross accumulate. And what does cross accumulate mean? Well, the deductible can be met in the out of network, and it'll be met. It'll also be applied to the in network. There are some. Remember, this goes back to the benefit that the employer picked. This doesn't work for everyone or everything, but you need to be aware of this as you process for a deductible for either in or out of network. There are some plans, provider benefit plans, that will process in both directions. So usually, if the out-of-network deductible is being applied, it will also apply to the in-network deductible in a lot of cases. It's just a matter of the benefit plan, though, as to how that actually happens. So you have to actually look and ask those questions to the insurance company as you're doing the pre-verification. So if you only go to an in-network deductible, there are some cases where the provider benefit, it'll only be applied to the in-network, and it won't apply to the out-of-network deductible. But someone will cross-accumulate where they'll apply to both. Thank you. That was a good question. Next question, please.
Thank you. What does daily max cap mean? Per diem cap?
Yeah, per diem cap or daily max cap. The insurance companies will call it different things. Literally what it means is that if you are out of network and you call them the employer's benefit, let's say, I'm just going to pick an arbitrary one, say General Motors, for their transmission division out of Detroit, decided that they didn't want to pay ambulatory surgery center usual and customary rates. So they put a maximum cap plan on top as to how much they're going to pay, and they say they will tie that to, say, $350, $380, $1048. They will tie that maximum out-of-pocket, the maximum reimbursement they're going to pay for any given day of surgery is tied to that rate. So you want to ask that proper question when you're talking about billing out of network. You want to know if you want a per diem cap or a max cap. Thank you very much. Next question.
Okay, we have time for just one more question today. If you are out of network with one insurance, do you have to be out with all carriers?
Oh, thank you. That's a good question. No, you do not have to be out with all carriers. That's where we talk about the hybrid mix or a different mix. If you're out of network with one, you don't have to be out with all. You just have to look at your fee schedule and structure your fee schedule so that you're charging a fair amount to all those patients. But literally, you can be out of network with, say, Cigna, or stay out of network with Aetna and stay in network with Blue Cross. And we're seeing a lot of ambulatory surgery centers doing that these days because they're unhappy with some of their contracts. And if you'd like more information on that, feel free to contact us. Thank you very much.
Okay, thank you, Kelly. And for the attendees, again, Kelly can be contacted. You can see his contact information on the last screen up here, kelly.webb@metagain.com, or his phone number is 888-244-4754 if you have any additional questions. We thank you for participating. Yes.
I was just going to end it. One last thing is that if there's been a whole lot of other questions that have been texted in, we're going to continue to answer those after the seminar completes and try to contact you and answer your questions fully through email or any other method possible. So thank you for tuning in.
Okay, great. Thank you. And we look forward to having everyone join us again for future webinars. This will end today's program, and have a good afternoon.